Hello, everyone, and welcome to the TMA Ask the Expert podcast series. Today, we are hosting a special town hall on a multi-center study called CAPTURE, funded by the Patient-Centered Outcomes Research Institute, Pukori. I'm Chitra Krishnan, Executive Director of the TMA. We are a nonprofit focused on support, education, and research of rare neuroimmune diseases. You can learn more about us on our website at myelitis.org. This podcast is being recorded and will be made available on the TMA website for download via iTunes. During the call, if you have any additional questions, please send them to us via our Facebook page at facebook.com/myelitis, or you can send a message through the chat option available with GoToWebinar. The 2015 TMA Ask the Expert podcast series is made possible in part through the generous support of Chugai Pharmaceutical Company and Alexion Pharmaceuticals Incorporated. Chugai Pharmaceutical Company is conducting clinical studies to create original and innovative drugs, both in the US and overseas, to address unmet medical needs in neurological disorders where the level of pharmaceutical contribution and satisfaction concerning patient treatment remains low. Alexion Pharmaceuticals is a global biopharmaceutical company focused on serving patients with severe and rare disorders through the innovation, development, and commercialization of life-transforming therapeutic products. For today's podcast, we are pleased to be joined by Dr. Benjamin Greenberg from University of Texas Southwestern, who is leading this multi-center study, and Dr. Brenda Banwell and Dr. Sarah Hopkins from Children's Hospital of Philadelphia. And today's conversation will be moderated by Patricia Plum, Senior Research Nurse at University of Texas Southwestern. Over to you, Tricia, to introduce our panelists today and to start us off.
Thanks very much, Chitra. It's a pleasure to be here today, and a very warm welcome to our experts on the panel today. First, we have Dr. Greenberg, is recognized internationally as an expert in rare autoimmune disorders of the central nervous system. He splits his clinical time between seeing both adult and pediatric patients. His research interests are both in diagnosis and treatment of transverse myelitis, neuromyelitis optica, encephalitis, multiple sclerosis, and infections of the nervous system. He currently serves as the director of the Neurosciences Clinical Research Center at UT Southwestern and is a Cain Dennis Foundation Scholar. Dr. Greenberg is a member of the board of directors at the Transverse Myelitis Association and also chairs the TMA Medical and Scientific Council. Welcome, Dr. Greenberg. Dr. Banwell is the chief of neurology at the Children's Hospital of Philadelphia. Her clinical and research interests are in pediatric multiple sclerosis and other inflammatory brain disorders. She remains the lead investigator of the Canadian Pediatric Demyelinating Disease Program, which has now partnered with the Pediatric Demyelinating Disease Program in Philadelphia. At CHOP, Dr. Banwell is the director of the Pediatric Multiple Sclerosis Clinic, a multidisciplinary clinic dedicated to children with multiple sclerosis and other acquired demyelinating diseases. Her clinical studies focus on the cognitive and neuroimaging features of pediatric multiple sclerosis, while the basic science work focuses on T and B cell autoimmunity studies, MRI imaging, and studies of viral triggers. Welcome, Dr. Banwell. And we also have Dr. Sarah Hopkins. She is a pediatric neurologist at the Children's Hospital of Philadelphia as well. She is an associate professor of clinical neurology, Perelman School of Medicine at the University of Pennsylvania. She sees patients in pediatric multiple sclerosis clinic at CHOP as well and has an interest in transverse myelitis. She completed her medical school at the University of Arkansas in Little Rock, Arkansas, her pediatric residency and fellowship in child neurology at Cincinnati Children's Hospital Medical Center in Cincinnati, Ohio. Dr. Hopkins has also a graduate degree in epidemiology at the Rollins School of Public Health, Emory University, Atlanta, Georgia. Thank you all very much for joining. So to start us off, Dr. Greenberg, what is the CAPTURE study and what do we hope to achieve?
Well, Tricia, first, thank you for leading the conversation, and to the Transverse Myelitis Association for sponsoring these podcasts, and to Brenda and Sarah for taking part. The CAPTURE study is an international multi-center collaborative study, and I stress the word collaboration because even though, well, on paper, I am listed as a lead, this project does not happen without a group of people, colleagues like Dr. Banwell and Dr. Hopkins and folks at the Kennedy Krieger Institute in Baltimore, Johns Hopkins, and in Toronto at SickKids, where we are trying to get a better understanding of what happens to pediatric patients with transverse myelitis. This is an observational study, meaning we do not prescribe or randomize patients to receive different treatments, but we are tracking their data, both in terms of how they were diagnosed, how they were treated, and then what type of outcome they achieved over a period of at least a year. Surprisingly, there has not been a prospective longitudinal study of transverse myelitis outcomes ever. All of the outcomes data we have has been based on retrospective reviews. So we felt as a group that it would be meaningful to understand prospectively what happened to patients, understand, if we could, what possible causes there were, and then ultimately what the outcomes were, so that we could start to inform patients, families, and clinicians about how patients were responding to different treatments.
Fantastic. Thank you. Dr. Banwell, as someone who has led national efforts in pediatric demyelinating diseases, why do you think this study is important? And if we had a glimpse at the future, what can we hope to learn?
Okay, can you hear me?
Clear as a bell?
Okay, super. So first of all, thank you, Ben, and all of you for including me in this podcast as well. So I have had the privilege of coordinating a large study looking at demyelination of the central nervous system in children. And as Ben mentioned, this really word coordination is the key phrase. This is a multidisciplinary, multi-PI, multi-investigator initiative. I think the first statement I would make is that transverse myelitis is one of the acquired demyelinating disorders, and like all of them, these are rare. And so in order to understand a rare condition, you need extensive collaborative networks to both have the sufficient number of patients to inform on the clinical features and outcomes, and also a diverse group of patients in order to better understand what makes the clinical feature, outcome, or biology informative as to either cause, course, outcome, and ultimately therapeutic strategies that would be effective broadly and individually. So the national program in National Plus CHOP program now in Canada and here in Philadelphia looked at children with the first demyelinating event, and our first phase of that project was what were the clinical features that identified these children, what were their short-term outcomes in the first 5 years, and then we started to explore key factors that we thought might be indicative of whether this was a single event or a chronic disease such as multiple sclerosis or neuromyelitis optica. Our second phase of the project, which was the second 5-year window, looked more comprehensively at the clinical outcomes now that we had a longer period of follow-up. We started looking at patient-relevant or patient-centered outcomes like quality of life, also much more in-depth analysis of visual function. And then we went further into imaging, and so in the first phase we looked at what are the sort of photographic appearances of demyelination using conventional, typical MRIs. In the second phase of our project, we used more advanced imaging to try to probe what was going on when the immune system attacked in the brain in particular, less so in the spine on that study, but focused particularly on were there abnormalities in areas that were visibly involved with the attack or chronic disease like MS, or were there also findings in areas that looked normal, so exploring more thoroughly the underlying MRI appearance of the brain in children with demyelination. And then in the immune aspects, a more comprehensive and much more difficult set of experiments to try to understand what makes the immune system different. Both, and I think very importantly, in kids who have a one-time attack, how do they regain immune control from children who are unable to do that and develop a chronic or have already demonstrated a chronic disease. We're now moving into our third phase. We just recently were funded, and we've in June to have a third phase of this project, where we're really now going to look at how do these young children and teenagers do as young adults, what's the impact on their vocational and subsequent societal success in terms of life goals and achievement. We're going to be able to look now much more comprehensively at the impact of any inflammatory insult on brain growth and upper spinal cord integrity, and looking even more detail at the regulatory aspects of the immune system. So what I'm trying to illustrate is the objective of a multifaceted research program that has been designed specifically to include high-level clinical observations so that we always keep foremost in our objectives a program that is focused on the patient. So I think the CAPTURE study has this objective as well and touches on many of the same themes: collaboration, patient-centered outcomes, prospective ascertainment of clinical and ultimately future biological and imaging variables, and then, most importantly, if patients do really well, why, and if patients struggle and have more deficits, what could we do differently, hopefully in the future, to mitigate that?
That is an amazing body of work over several different phases, and I love that it's absolutely longitudinal and that it's patient-centered. Speaking of patient-centered, you are welcome as an audience to please type in your questions in the chat window, but you please use the GoToWebinar. Thank you. So Dr. Hopkins, would you please tell us what is transverse myelitis? And if you can also say, let us know what is acute flaccid myelitis and how are they diagnosed?
So first of all, I just wanted to thank the TMA for including me today. I've had the pleasure of listening to several of these podcasts, and they're really incredibly informative and I think very valuable, so I'm happy to be here. So transverse myelitis is a rare neuroimmune condition that causes inflammation of the spinal cord, and patients can present with weakness, sensory changes, and often some degree of bowel or bladder function as well. Unfortunately, there are often some residual difficulties with paralysis after the episode. Often, cases are associated with an infection, such as a GI or respiratory infection that occurs before the initial onset, but it may also be secondary to another disorder, such as multiple sclerosis, neuromyelitis optica, or even some other inflammatory disorders, such as lupus. And acute flaccid myelitis is, different from transverse myelitis because while it involves inflammation of the spinal cord, it involves a very specific portion that's called the anterior horn, which is in the gray matter of the cord. This area contains nerve cells that send messages from the spinal cord out to the muscles. And when these anterior horn cells are injured, then the patient is unable to move the part of the body that those nerve cells had been supplying. So most commonly, the patient will have a significant amount of weakness in one or more of their extremities. And they can also have involvement of their cranial nerves. Different from our other patients with transverse myelitis, they don't really tend to have the changes to their sensory function or to their bowel or bladder function. Acute flaccid myelitis has also, of course, had increased attention since about August 2014, when there was the increase in cases noted in Colorado and then in other areas of the country. This was temporarily associated with an outbreak of severe respiratory illness related to enterovirus D68, although there's not been a definitive connection established there. The other thing that's interesting, I think, about acute flaccid myelitis is that it's not entirely clear whether this is kind of an infection of the nerve cells or post-infectious inflammation there in the cord. The way that we diagnose these disorders is really just by looking for evidence of inflammation to the spinal cord. There are two main ways that we do this. One is with MRI images, looking for bright spots on T2 weighted images, specifically with contrast enhancement. That's an indicator of inflammation, and also with increased white blood cells in the cerebrospinal fluid. Sometimes just as important to making the diagnosis of transverse myelitis is ruling out other things that are potential causes of similar symptoms. So we're always very careful about ruling out things such as spinal cord compression and ruling out, for instance, vascular diagnoses that could cause a stroke to the cord that could in some cases have a similar imaging appearance.
Oh, fantastic. A very comprehensive answer. Thank you. So Dr. Greenberg, what are the standard treatments currently offered in the acute phase for transverse myelitis?
Yeah, so it's interesting to use the term standard treatments because I think in the setting of transverse myelitis, we've had an evolution in our thinking about this. for decades now, the mainstay of therapy has involved the use of steroids as a way to treat inflammation in the spinal cord. And then beyond steroids, pretty uniformly, there's been the use of either a procedure called plasma exchange, a medical treatment with an infusion called IVIG, which stands for intravenous immunoglobulins, and in some cases, certain chemotherapeutic medications immunosuppress a patient. And one of the reasons CAPTURE came about was we do not have a consensus on what to do beyond steroids, whether it should be IVIG, plasma exchange, both, and in what order. And case by case, facility by facility, there was great variability and I think certain investigator biases where we all have a favorite for certain situations. So part of CAPTURE is to sort out what happens to children who get the various treatments and to see if we can start to gain insight on whether or not there is a best practice. I think we would all agree the best practice is early accurate diagnosis, early initiation of steroids, and in the cases of children who have severe deficits, early initiation of adjunct therapy to steroids, such as plasmapheresis or IVIG. It's worth noting at this point there's been allusions by everybody on the call to the focus of CAPTURE, which is very much patient-centered. And we have yet to recognize that the funding for this came from an organization known as PCORI, the Patient-Centered Outcomes Research Institute, which is a private entity that was funded by the U.S. federal government to support research efforts that would ask difficult questions but use patient-centered input and metrics to obtain the answers, with the view that while I may see hundreds and thousands of patients with these conditions, we really need to rely on our patients and our families to give us guidance on what is the long-term impact, benefit, or lack of benefit from our interventions. So the CAPTURE study funded by PCORI is very much looking at these treatments to decide what incremental benefits does each one offer. This will not be a definitive study to determine which is the best treatment, but without it, we will be wholly unable to do definitive studies in the future. This study will give us a sense as to what the variance and range of recoveries are and what are the possible study designs that we could use to get the ultimate answers so that treatment is better for patients moving forward.
Thank you. Thank you very much. So we do have a question from our community, and this happens to talk about the acute care setting, and it is, have there been any reported instances of pediatric transverse myelitis due to vaccines? Dr. Hopkins, would you like to take that one?
So there have been some individual case reports of transverse myelitis potentially associated with vaccinations. I think that's an extraordinarily hard question to answer, because so often with children especially, there's a lot going on at any one time. You know, nothing occurs in a vacuum. So you may have a child have a vaccine, you know, for instance, the flu vaccine, but that's also in flu season, and there's also, you know, other infections going around at the time. So I think time-wise, that definitive connection between vaccines and transverse myelitis is a difficult one to make.
Yep. Thank you, Dr. Hopkins. So, Dr. Banwell, would you please give us a little bit of insight as to what do we know about recovery after an acute demyelinating event?
Sure. And I just want to echo one further comment, if I could, about the vaccine story. There's, you know, I think it's important to note that there are vaccine surveillance programs in North America, the U.S. and Canada, and other countries, I'm sure, as well. But I can speak to both the U.S. and the Canadian perspective. And so I think it's important that people realize that when universal vaccinations are launched, or near universal vaccinations by pure chance alone, you are going to end up with a circumstance that someone has some illness in close temporal proximity to an exposure of a particular vaccine. If you vaccinate everyone, that's going to happen. And I think that with transverse myelitis, we're very, very careful to make sure that there's no increased frequency of transverse myelitis in the same time period as a particular vaccine program or when a new vaccine comes out. And the evidence linking transverse myelitis with any one vaccine is very, very weak. I think the lessons learned in the autism story, where there was, unfortunately, as many of you on the call may know, falsified information of an investigator who's now actually incarcerated in the UK, linking that to autism. That also was because autism, for example, is often diagnosed, or the first symptoms are recognized in the time period where children are receiving multiple vaccines. That's not because the vaccines necessarily have any relationship at all, but maybe because children receive most of their primary series during the window when their developmental progress is identified as being perhaps not within the normal spectrum, and that leads to their autism diagnosis. So I'm highlighting that story just to emphasize that to make a causal relationship, you need multiple levels of evidence. And happily, the vaccines that we're using right now have proven to be quite safe. In terms of your next question, I'm sorry, I was so focused on that I lost the question.
That's okay. That is no problem. And so could you please comment on what do we know about the recovery after an acute demyelinating event?
Okay, so it certainly depends on the company in which the demyelinating event keeps. So in children who have acquired monophasic demyelination, and these are children who in prospective studies have been shown to not have further events, to not have the clinical course of multiple sclerosis, to not have the clinical course or serological blood work implicating neuromyelitis optica spectrum disorders. So these are children who have a one-time attack. Approximately 20% of those children will be left with a significant neurological deficit following their myelitis event. Either typically motor impairment, a gait impairment, weakness if it's the lower extremities that are predominantly involved, or upper limb weakness if that was the predominant region of the cord involved. And about 80% appear to recover either fully or near fully. And I say near fully because it is sometimes difficult to determine whether they are subsequently quite as athletic as they might have been if they hadn't had transverse myelitis, especially if the myelitis episode was when they were quite young. But functionally, they improve well motorically about 80% of the time. Now, and I'm being fairly broad. Bladder recovery, however, is not always as good. And there was a series from the Hopkins group, and similarly, we looked at our transverse myelitis series in Toronto. And if you question your patient carefully, about 50 to 70% of kids will have some ongoing bladder dysfunction if they had bladder impairment at the time of their transverse myelitis. Key to this is asking the question and having a level of comfort with your patient that's confident in telling you that they occasionally lose bladder control when they run, or that they're, have some issues with bladder control. And obviously that requires a good private conversation with your patient, particularly the teenagers. So that's monophasic myelitis, generally speaking. The recovery from a myelitis attack when it represents one of the attacks in multiple sclerosis acutely is generally quite good. Most children have a partial myelitis. They typically recover well from a strength perspective. Sensory recovery in a multiple sclerosis spinal cord attack tends to lag behind the motor recovery. And patients can have a persistent Lermite symptom, which is that electrical feeling when they forward flex their neck or bend forward to reach toward the ground. That can persist even longer. And it actually can also be the sentinel warning signs that they're having a myelitis attack. Those eventually typically go away. So early on, most children with multiple sclerosis do not have residual spinal cord deficits. We don't yet know the impact of spinal cord disease on the long-term risk of secondary progressive MS in kids. And I think that is going to be something we'll learn more about with time. But we don't see a progressive spinal cord myelopathy in pediatric MS patients during childhood and teenage years. And then finally, with neuromyelitis optica, where spinal cord involvement is one of the cardinal clinical symptoms, the recovery from those attacks can be poor. And I think we're getting a sense that perhaps in pediatric neuromyelitis optica, it might not be quite as poor as it is in adult onset neuromyelitis optica, but I think we have far too little data on that. And of course, all of this is challenged by the rarity of spinal cord inflammation and the different groups of patients that may experience it. I would also say that there may be certain clinical patient groups that do less well. In particular, there are several reports indicating that African American patients do particularly poorly with least neuromyelitis optica related spinal cord disease. And that actually appears to be true, generally speaking, across all of the inflammatory disorders where that particular factor has been investigated. So take home, if it's an isolated spinal cord inflammatory event not linked to chronic disease, physical motor recovery occurs about 80% of the time, and bladder recovery can be less promising. And then in chronic patients, neuromyelitis optica appears to be a more severe spinal cord manifestation.
Wow, thank you a million times over, Dr. Banwell. So in our community, we have a running theme of questions, and I get this from the parents I speak with as well, and it is a lot of families are wondering if this can recur. Can transverse myelitis happen again? Dr. Greenberg, would you care to comment?
Yeah, I think this is a understandable and legitimate concern on the parts of our families and our patients. There's a short and a medium to long answer. The short answer is, in general, no. And there is an assumption baked into that, and that is that the evaluation of the child, either at the time of the onset or during the early follow-up, has been appropriate and thorough. Pediatric patients and adult patients alike who have transverse myelitis need to undergo a series of tests with imaging, blood work, spinal fluid to look for certain markers that are suggestive of systemic conditions that may come back. The easiest example is the blood test for the NMO antibody. If a patient, regardless of age, has transverse myelitis and has a positive test result for the antibody, meaning they have this antibody circulating in them, then their chance of recurrence is extremely high. But assuming that a child has had the full evaluation, T's crossed, I's dotted, and I know our group and the group at CHOP are somewhat compulsive about this in terms of turning over every stone. Once those have been turned over, thankfully the recurrence rate in pediatric idiopathic transverse myelitis patients is extraordinarily small. And so I am very comfortable looking patients and families in the eye saying, I'm not worried about recurrence once we have done the appropriate testing and follow-up. There are some situations where there may be inconclusive results or testing that was done in the setting of certain treatments where we're not convinced that a negative result is truly negative until we repeat it 3 or 6 months later. But assuming that follow-up and that thoughtfulness is being provided, if no cause is found, then recurrence rates are extremely, extremely low.
Fantastic. Can anyone have a pseudo or a fake recurrence of symptoms?
Yeah, I'm glad you asked and prompted that. It's important, you're right, to separate out the recurrence of symptoms from the recurrence of inflammation. Once a spinal cord has been damaged by inflammation and a patient recovers, the recovery occurs for a variety of biologic reasons. It can occur because the spinal cord is repairing, and it can occur because the nervous system is learning to compensate for the damage that's done. In either instance, even in patients who have 100% resolution of their symptoms, so we've taken care of some patients here at Children's who came in and could not move a leg, could not feel a thing, could not empty their bladder, and after the therapy in the hospital and after the rehab, they're back to being varsity ice hockey players and have a totally normal neurologic exam. So truly 100% recoveries. Even those patients may intermittently experience the return of old symptoms. On a hot day, running around, they may get some tingling in their feet. In the setting of a urinary tract infection, weakness may come back. And this phenomenon, which is called Uthoff's phenomenon, has to do with a systemic stress on the body making it harder for the nervous system to compensate for the damage that was done. So symptoms come back, but there is not new damage occurring to the spinal cord. So when patients experience a emergence or reemergence of symptoms relative to their spinal cord, it's upon us, the clinicians, partnering with our patients and families to try and understand why and to sort out, is this a return of inflammation or is there some sort of stress on the body that's bringing the symptoms back again? Almost always we can find a source of stress on the body that's bringing the symptoms back again, and when we get rid of it, when the child cools off or when we treat the infection, the symptoms go away.
Okay, fantastic, Dr. Greenberg. So we have about a half an hour left, and we've talked extensively about more of the acute and etiology, but I kind of want to segue into a little bit about what is in store for the future and how if families are interested, how they can participate. So Dr. Banwell, can you let us know how families can benefit from participating in the CAPTURE study?
Sure. I think there's several aspects that are relevant to families that are gained, things that are gained by participating in any sort of project. First of all, any family that is so generous with their time is contributing to a greater understanding of an illness that's relevant to their child as well as to many other people's children, and there is power in numbers. The more that more information we have, the better able we are to tease apart things that are contributing to the disease, to its outcome, or to its management, versus factors that are not relevant. Second, there's a sense of community when families participate in a project or a research program, and a sense of pride that they have contributed to the overall understanding of the condition. And so I think a lot of families gain sort of a little bit more autonomy, a little bit more sort of control in the sense that they are actively doing something about what's going on in their family and what's happened to their child. And then, of course, at the highest level is that the research that will come from better understanding the clinical features, the imaging features, and the immunology may directly benefit families, including their own child down the road, either by understanding factors that would predict recurrence and therefore identifying children that need preventative medicines, to maybe blood work that might indicate particular patterns of immune cell behavior that might indicate when a child's immune system is about to misbehave and how we might intervene on that, as well as blood or MRI findings that may indicate that a child really is truly not going to have this happen again, and have the reassurance that all things investigated look like this is a one-time event and we should be focusing on recovery, not worrying in that particular child about recurrence. So I think that all of those are really important. We've had very high retention of families in our Canadian pediatric study, I think for all of those reasons. I think if you ask families, and some of them have now been part of our program for more than 10 years, they really feel like they've been part of something and they know what it is that they've been part of, and they've been engaged from the beginning. And I think that that's been a terrific experience for all of us. And we have learned things that we think are relevant to our patients on multiple levels. So I think there's a huge gain for families. And I also think this is their story. And understanding what they've gone through also helps other families who are facing this unimaginable experience where their previously healthy child is suddenly in the intensive care unit or in the hospital with an acute myelitis.
Yeah, I know it's an incredibly scary time for families involved when that happens. So, Dr. Hopkins, can you talk a little bit about, as a child is enrolled in the study, what kind of outcome measures you are doing and how much time does it take for the families? Hello?
Oh, I'm sorry. I forgot to take myself off mute.
Welcome back.
Thank you very much. So I think that's really one of the neatest parts about the CAPTURE study from my perspective. Demyelinating disease in general and TM in particular, we still haven't really landed on, what's the best way to know how our patients are doing over time and how have they done over time. So in the CAPTURE study is nice because we've got two different groups of people. We've got the groups of people who are doing the questionnaires plus being seen in clinic. And then we've got the group of people that's just doing the questionnaires online. And the patients that we're seeing at the study centers that we can examine, we can correlate their data, we can correlate their what we see in clinic with how they fill out their questionnaires and validate the questionnaires that they complete. And that's really valuable, I think, in terms of the overall, knowing that we're getting really good, strong information from the questionnaires from the online cohort. There are a number of outcome measures that we're looking at, and one is called the WeFIM, which is a test that's part of the test can be done in clinic with exams and questionnaires, and also it can be filled out as a questionnaire online. And there are other tests that we do in clinic, such as the 6-minute timed walk, and a spasticity scale looking at the tightness of the muscles. So in general, if a patient comes to CHOP for an initial study visit, they'll have their normal visit with the physician plus generally about an additional hour of additional questionnaires and testing. And then when the patients are in the online cohort and completing the online questionnaires, the estimate would be in around the 20-minute kind of range.
Okay. So it's nice. So families are able to participate when they would normally be coming back to an office visit.
Yes, so we try as best as we can to coordinate it with the clinical care that the patient's already receiving. So it's not, it is a little bit of extra time for each visit, about an hour or so, but beyond that, at least they were going to be making the trip to CHOP anyway.
Right. Thank you, Dr. Hopkins. So Dr. Greenberg, can you please comment on what are some long-term plans for the CAPTURE study? And how does someone who's had transverse myelitis a few years ago, are they able to contribute?
Yeah, so great question. So for the current version of the CAPTURE study, the long-term plan is based on a unique partnership with the TMA, where we plan to keep an infrastructure for the data collection going long after the formal funding from PCORI runs out. And what I mean by that is when we're in a study and collecting data, it takes a lot of resources to get that started, from the design of the data capture to the instruments to paying the salaries of staff all across the North America to recruit and collect this data. But once an infrastructure gets going, we want that data to continue to grow and be used by patients and clinicians in the future. And what the TMA has done is partner with a group called TraitWise, and we are going to be able to add to this data set for years to come and allow clinicians and researchers to query the data set so that when they're treating a patient, they can selectively look at data from similar patients who came before. So, for example, a clinician who's never been part of this study will be able to access the data system and say, I have a 9-year-old girl who has this type of lesion and this spinal fluid. In prior experiences, how did they do with different treatments? And the database will pull out similar patients and give that clinician more granular guidance about what happens to, or what has happened to patients in the past with different therapies. And so we think that'll be a huge asset, a legacy, if you will, to leave from the CAPTURE study and keep it living for years and hopefully decades to come. What we have also recognized is the CAPTURE study as it was designed was pediatric focused and was dependent on enrolling patients who were in the first 6 months of their event. But there is a lot to be learned from the thousands of patients who have had TM a year, 2 years, 5 years, 10 years ago. We are in the process of designing what that will look like in terms of an additional, a CAPTURE 2, if you will, to really create a scientifically sound way to collect data, validate it, and make it useful to clinicians and patients so that we can start to understand what the natural evolution is of this disease and what are the treatments that may or may not be helping. So what I would say is stay tuned and stay engaged with the Transverse Myelitis Association because we fully expect to be able to roll that out.
Thank you, Dr. Greenberg. That's wonderful news to hear that there's so much hope for the future. And so I have a question for Dr. Hopkins that is coming from the community. And how rare is family autoimmune disease? Can it be passed from generation to generation? Have you got that mute on?
So, nope, I don't have it on.
Okay.
Just taking a second. So, well, we think that some families do overall tend to have a tendency to have more autoimmune disease in general. For instance, you may have a family who, one family member has autoimmune thyroiditis, another has lupus, maybe another family member has multiple sclerosis, and there are certain genetic tendencies that may go along with that. It is much more rare for instance, families to have it would be unusual for one family member to have transverse myelitis and then another family member to have transverse myelitis as well. So there doesn't seem to be a genetic predisposition for transverse myelitis in particular. Some of the other demyelinating conditions, such as multiple sclerosis, do have some genetic tendency, but there is still far and beyond that genetic tendency, there's the contribution of environmental factors, which is going to be much more important overall.
Great, thank you. So let's see, okay, so Dr. Banwell, can you comment on how this pediatric study may have anything applicable for the adult transverse myelitis or acute flaccid myelitis community?
Sure. Well, I think as a first step, we have essentially shown, at least in pediatric multiple sclerosis and perhaps increasingly now in neuromyelitis optica, that the pediatric sort of version of these illnesses is really, at least the biological level, pretty similar, if not identical, to the adult onset diseases. There are differences in disease expression that relate to the age, maturity of the host in terms of white matter maturity, immune cell behavior, and maybe even time relationship to risk factors that might distinguish pediatric patients a little bit from adults. But in terms of a lot of the other genetic and ultimately MRI signatures of these conditions over time, they appear to be very similar. So I think what we learn in children is applicable to adults, and if anything, we might learn more in the pediatric context about the earliest aspects of a condition, at least in the chronic illnesses, because children, by virtue of only being 5, 6, 7, 8 years of age, are by time alone closer to exposure to those factors that drive the biology of the disease at its onset than somebody who may have had a sort of subclinical period of disease activity as an adult that could have gone on for several years before they had their first clinical real attack. Now, in monophasic transverse myelitis, which is the majority of patients with transverse myelitis, that may or may not be, the pediatric advantage, if it's an advantage, I don't mean advantage overall, but in terms of understanding biology, if in children and adults the time course is such that whatever starts the process and then turns the immune system on to attack the spinal cord might be quite short in both patient groups. I think having a good understanding of recovery in a pediatric patient population will be both helpful for adults, because we may learn ways to make patients recover more effectively, but may also be a little bit different in that how well we recover from anything is different by age. So if you break your arm, you recover more quickly if you're 6 than if you're 60. We don't know if that's true in the spinal cord, but certainly that we will have to look at the types of recovery and mechanisms of recovery as a function of age. So I think the PCOR study will definitely inform on the pediatric context, and I think it's going to be very valuable for adults as well, with the caveat that we have to think about development.
Fantastic. Thank you very, very much. I know we've had a few families who were very concerned about patient privacy in this day and age where we hear a lot about identity theft. We have some families who ask about how is my child's information protected in this study. So Dr. Greenberg, are you able to comment?
Yeah. So can you hear me okay? I transitioned to a phone. So it's a very valid concern, and we take this very seriously in terms of doing everything we can to protect confidentiality. When the data from visits or medical records are obtained, they are abstracted into a database that does not have the individual's name. We assign a unique code such that if there ever was a hacker from another country who broke into the database and took out all the data, what they would have was a bunch of information. They'd have my age and notes about my MRI, but they wouldn't have my name, my address. They wouldn't have anything that identified me. They would just know that I was the children's patient number 3. The database that links those codes to any identifiers are kept completely separate and secure and are not on open networks where they could be pulled down. So we take every precaution we can to keep those links separate and to keep patient's identity confidential. That said, in the world we live in, while we do everything we can to reduce the risk, that I think is a legitimate concern and one that families have to weigh when providing information. We do the best we can, and I think we do a very good job, but as we all read the news of people getting into IRS and Pentagon files, I'm not about to say that the children's database network is as secure as a Pentagon, but we do our best to make sure that the actions we take and the way we handle the data is done with a very sensitive view towards confidentiality.
Thank you. I know that confidentiality is on a lot of families' mind, and so thank you for clearing that up. Okay. So we do have another question from the community, so I'm going to segue back because this one actually is about, of course, about vaccines. And so we have someone asking, do you get the flu shot or not, dead or alive? If it's dead, is there a difference between multi-vial versus single-vial shot? Should we ask for a thimerosal-free vaccine? Dr. Banwell?
Okay, all good questions. I'll start with the flu shot. So I'll start with vaccines in general. So if a person has recently had an acute inflammatory myelitis, and there's no study that has looked at exactly what recent should mean, but in my practice, I mean within the last 6 months. I tend to hold vaccines until they are at least 6 months out from their prior illness. I do this first and foremost I do this for sort of 2 main reasons. Three main reasons. One, if the kids have been recently treated with immune suppressive therapy during recovery, so if they've had steroid therapy, less worrisome plasma exchange or immune globulin, but if a patient has had a really severe myelitis, they may even have been given treatments that suppress the immune system further temporarily. They may not respond to the vaccine very well, and therefore it seems it's ineffective to give them a vaccine too close to the time point when you've given the medicine to turn the ability of the immune system to respond down. So I want to wait until they've recovered from the treatment and from the myelitis itself. Second, given that we believe that a portion of transverse myelitis is related to an abnormally turned on immune system, it seems ill-advised to give a vaccine that also turns the immune system on, albeit differently, in close time frame to when the patient has just had an abnormal immune response. So for that reason, I tend to wait 6 months on that count. And third, because transverse myelitis, while we talk about monophasic or an illness that has a one time point being the commonest expression, that period of illness can vary between different people. So some children go from being healthy to being severely involved in a matter of days. Other patients develop symptoms over more of a slow period, even up to a couple weeks. If a vaccine were to be given in a close time point to the onset of their myelitis, you might falsely link any change in their clinical outcome, or not falsely, but you might link any change in their clinical state to the fact that they received a vaccine in that time window. And I hate to link those two things, when we can avoid it. So I wait 6 months after a myelitis event before giving any vaccines, irrespective of the type of vaccine. That's step 1. Step 2, if you are not on any chronic immune suppressant therapy and you're more than 6 months from the myelitis, I don't discriminate between live or attenuated vaccines as long as it's not a new vaccine that we don't know the history of. There's a couple of vaccines to watch a little more closely. So the simple rabies vaccine, for example, which would be a very uncommon thing to need, is one that has been perhaps more implicated in causing problems. So I'm careful about the type of vaccine, but for the majority of vaccines, that would not be an issue if they're not on immune suppressant therapy. And then finally, with respect to Thiamidol or any other adjuvant that's put into vaccines, to my knowledge, there's never been any good evidence that those additives are themselves. I am not an expert on vaccine content, but I understand that a lot of those additives, particularly Thimerosal, are no longer in most vaccines, but I really don't know exactly which vaccines do or don't have it, but I'm not aware of any good evidence that additive is directly linked to any myelitis episodes. Happy if Ben or Sarah have any different opinion on that.
Okay, thank you. I know that that has been a running theme for several families. So we will take one more question from the audience because we're going to be wrapping it up here in just a moment. So Dr. Hopkins, can you please, hang on just a second, sorry. So we had a family member asking about what do families, you spoke of the treatments during the acute phase. What we're interested in is after the acute phase. Is it solely up to the patient's own recovery rate? I think we might have lost Dr. Hopkins. Can either Dr.
Greenberg?
So Dr. Greenberg spoke about the acute treatments very nicely. In terms of ongoing, I think maybe the question is speaking about immunosuppression, but I'm not 100% sure. In terms of ongoing immunosuppression, that would be determined by the patient's clinical course and the thought about whether or not there may be there may be another underlying autoimmune disorder going on. For instance, if there were brain lesions to suggest multiple sclerosis, if the patient was NMO antibody positive, or perhaps had a fulminant presentation that was suggestive of neuromyelitis optica, then those are times when we would consider instituting more aggressive immunosuppression over time. I'm sorry, I'm really getting a lot of feedback suddenly, and I'm not sure why.
Yep. Yes.
Tricia, if I may, and it may be I agree with Dr. Hopkins on the immunosuppression side. If the family's asking in terms of recovery from a functional status independent of the immunotherapy, then I would advise families to know that their child's outcome is not a preordained or destined event. There are things that can be done after the acute event very proactively to dramatically improve function, and at a minimum leave the door open for function to improve. I made reference earlier to, at least in my view, the two predominant ways a body recovers function. So one is by repair, and for that there's a time that is needed. The other is with compensation, and to a degree both compensation and repair are going to be dependent on use. I do not believe that our bodies are endowed with the ability to just fix things. We have to need it to be fixed. So if somebody adapts to what they need to do to live in a wheelchair, then there's no reason to ever get out of the wheelchair. So we constantly have to ask the human body to try and activate those neurons and activate those muscles and move the legs, move the arms, and do things from a rehab perspective to try and pull, push, prod, nudge, fight the body into repairing and compensating in a way that improves function. So after the acute event, there are a lot of things other than time, other than waiting for
spontaneous recovery that I think make a big difference in the various outcomes that children experience.
Great answer. Thank you very, very much. So we are just about out of time, and I just want to take a moment to thank you, our transverse myelitis community, for being so supportive of the CAPTURE study. And if you are interested in joining and you are recent diagnosis of within 6 months, please contact the Transverse Myelitis Association at myelitis.org. And I also want to thank Dr. Greenberg, Dr. Banwell, and Dr. Hopkins for giving us such valuable insight into pediatric transverse myelitis, and it was my pleasure to be a part of this as well.
Thank you for including me. It's Brenda.
Thank you so much.
Thank you.
Okay. Thank you.